So a very good morning to all. Today in morning session we'll discuss regarding the medical management of autism spectrum disorder. I hope since last one day you all people have been learning great things about autism spectrum disorder. So first, let me give a brief introduction. As you all know that autism spectrum disorder, as it is now called, it has been conceptualized or reconceptualized as a spectrum of conditions. So it is a diverse group of conditions, not a singular entity, like in other medical illnesses, like suppose we say malaria, it's a singular medical entity. But in autism, we define it as a spectrum of disorder. It is a continuum model, so it includes a diverse group of condition with heterogeneous features. So it's primarily characterized by two core symptoms. As we all know, there are deficits in social communication, social reciprocity. There are deficits, and there are restricted repetitive behaviors, interest, or activities. So characteristics of autism spectrum disorder may be detected in early childhood, but it's often not diagnosed until very later because of many issues, like there's lack of awareness or lack of sensitization among physicians, also among pediatricians also. So these are many issues which lead to this delay in the diagnosis. While some people are able to live independently, but most of the people suffer from disabilities ranging from mild to severe, and many people require a lifelong care and support. Evidence-based psychological interventions, psychosocial interventions are definitely help improving the communication and social skill, and have overall positive impact on well-being and quality of life, all on the patients and also on the caregivers. People with autism are often subject to stigma and discrimination and human right violations, as we know that there's due to lack of awareness, they are frequently regarded as having intellectual disability, or as the previous term was mental retardation, they were often considered as retarded. So all these stigma and discrimination still even exist today. So care of people with autism need to be accompanied by actions at community level and society level for greater accessibility, inclusivity, and support. Short about epidemiology, the burden of the problem has been increasing. There are many studies which do note that the prevalence of autism has been increasing in past couple of decades. So previously it was 1 in 500, but now many studies find that worldwide prevalence is about 1 in 160 children, and few studies, recent studies, have even found one in 60 68 around people are suffering from autism spectrum disorder among children. But it's very difficult to comment on the exact prevalence, especially in low and middle income countries, because the research is not that much robust or updated till now. So it's undergoing. um, so before we discuss about the management of medical management of ASD, first let's discuss what actually changed during DSM-5, the Diagnostic and Statistical Manual version 5. So previously in DSM-4, autism spectrum disorder were kept under the umbrella of pervasive developmental disorders, and it had many subtypes: autism, Asperger syndrome, Rett syndrome, childhood disintegrative disorders. But right now, after recent studies, especially twin studies, family studies, and other community studies, it has been found that this concept of distinct separate diagnostic entity is not that much useful. And nowadays the paradigm has shifted towards a continuum model. So it has been now reclassified as autism spectrum disorder. It's a spectrum of conditions, and many recent studies also denote that it may be a part of neurodiversity. So neurodiversity means like it's a part of normal neurological development. It's on the spectrum of normal neurological development towards when we discuss the normal distribution of development, so it's on the fringe side, but it's also it's not only a disorder in itself, but a part of normal neurological development. So one difference is the name has been changed. There has been inclusion of sensory differences in the criteria. Recommendation has been put to identify specifiers. So previously the criteria included language disorder or language deficit, but it has not been kept as a core deficit now, but as associated deficit. And we can specify that person is having autism spectrum disorder along with cognitive deficit or language deficit or intellectual impairment or other co-occurring comorbid mental or medical conditions, including catatonia. So previously we were not able to diagnose ADHD and ASD in a single patient, but now it has been included. So we can diagnose comorbid ADHD also in case of autism. So in any management, first and foremost thing is a good thorough assessment. So as we know that autism spectrum disorders are a complex neurodevelopmental disorders. So it's not possible to do a short or a single-handed assessment, and essentially needs to be done by a multidisciplinary team. So it includes a psychiatrist, a clinical psychologist, a special educator, occupational therapist, and speech therapist, audiologist. All these people should form a team and do thorough assessment of the child before moving on to any management. Assessment of co-occurring physical and mental conditions are also essential, because we find that frequently these people have comorbid physical anomalies also and mental issues also. So assessing them also at the same time is very important, otherwise the overall improvement will not be that much desirable as we want. So ruling out other conditions like hearing impairment, evaluation of comorbid conditions like seizure disorder. Frequently ASD is comorbid with seizure disorder. At around 30% of the children do have intellectual impairment also, IDD also. So we need to assess and rule out these conditions also. Also, it's very useful to search for underlying etiology if it is possible to find. So in various genetic syndrome or those having a syndromic child, we are able to find some chromosomal anomalies. So it's very useful to find these underlying anomalies so that proper intervention can be targeted. A medical history, birth history, and current health history and family history. These needs to be taken. Physical evaluation, physical examination, and developmental milestones, any dysmorphic facial features, any neurological deficits, skin manifestations need to be evaluated. Along with that, audiological evaluation is very important, as we have frequently come across that parents generally after the age of around 1.5 year to 2 year, if the child is not interacting properly, parents frequently think that their child is not able to hear, so they say some problem in hearing. So they frequently assume that some hearing problem is there. So doing a proper audiological evaluation is also very important. Genetic testing can be done in relevant child. Frequently, chromosomal anomalies could be found. Fragile X syndrome is one such syndrome, and other assays can be done. Other investigations include EEG for seizure disorder. Imaging studies can be done in case of dysmorphic skull features are there. If metabolic testing can be done, if there are comorbid medical conditions. So depending on the nature of the case, particular case, various medical examination and tests can be done. Investigations can be done for proper assessment and evaluation. Coming to the screening, it has been recommended that early screening is very useful because if we start the intervention early, the prognosis becomes very good. So, the American Academy of Pediatrics recommend that every child who comes for regular routine visits to a pediatrician or a physician should be screened at 9 months, 18 months, and 24 or 30 months. So it is the recommendation given by American Academy of Pediatrics, because frequently these are the time when most of the children, almost all, visit to a physician or a pediatrician for
This call
immunization.
is now being recorded.
Because these are the, according to national immunization schedule, during these months some vaccines are given to every child. So this provides a very great opportunity to screen them for neurodevelopmental disorders. American Association of Child and Adolescent Psychiatry also recommends ASD surveillance, and it also recommends that MCHAT scale can be used specifically at 18 month and 24 months, or if the need arises. So screening can is very simple, can be performed by physicians, also pediatricians, psychologists, or even special educators, occupational therapists. So special screening instruments are available which can be easily administered by any mental health professional. So MCHAT is one of that. It stands for Modified Checklist for Autism in Toddlers. The revised one is very easy to administer and can be used by many specialists to assess the risk for ASD. If the risk is found to be high or moderate, so we can go for further diagnostic tools. So as we know that these screening instruments have very high sensitivity, so the sensitivity is high, the specificity becomes low, so there is very high false positive rate. So we need to follow up the MCHAT with some follow-up questions known as MCHAT F. So by using these follow-up questions, we can find out what are those false positive and what are truly having autism spectrum disorders. So tools, many tools are there that include, most commonly used tools include autism diagnostic observation schedule, autism diagnostic interview. But for our Indian population, Government of India's Ministry of Social Justice and Empowerment have released a incline tool which has been developed by the government bodies, and it needs to be evaluated on the that's tool, so that the evaluation is uniform throughout, the assessment is uniform throughout the country. So it includes, the incline tool includes in itself another indigenously developed assessment tool known as ESA, Indian Scale for Assessment of Autism, which gives a cutoff score also, and also severity indices. It becomes very useful because it's very easy to interpret. We can easily understand whether a person is having autism or not, and also we can stratify the severity, and it also helps in certification because based on the score, the RPW guidelines have given the percentage of disability also. For disability certification, it becomes very useful. So we should not assume that these are diagnostic, because at the end of the day these only supplement the evaluation, and it should not replace the clinical judgment or clinical evaluation. So after evaluation, coming to the treatment part or management part, the non-pharmacological strategies or the psychosocial intervention form the mainstay of the treatment in cases of autism spectrum disorder, because there is no drug of choice exist. There is no one single drug or few drugs which have been considered as having a curative effect on autism spectrum disorder. So the medicines which are available are only supportive and mostly for comorbid condition or specific problems like irritability or sleep issues or hyperactivity. But in itself, autism curing medicine does not exist right now. So non-pharmacological treatment, the psychosocial interventions, the therapy, and all other psychological interventions form the mainstay of the treatment right now. So you all will be discussing these interventions in detail in other sessions. We'll just go over it rapidly. This early stage Denver model, it aims to develop the child in all domains. The intervention target are derived from assessment of developmental skills. So it stresses more on socio-communicative development, interpersonal engagement, imitation based development, social attention, and motivation. Another very widely used, very popular intervention used in autism spectrum disorder is ABA, Applied Behavior Analysis. ABA is based on the principle of functional behavioral analysis, FBA. It includes finding out doing the functional analysis of the child. What are the antecedents, what are the behavior, and what are the consequences of those behavior. So doing a functional analysis, behavioral analysis, and finding out the specific targets is very important in case of doing the ABA. It focuses on specific behavior, and it uses discrete trial to teach simple skills and then progresses to more complex skills and complex behavior. It's very helpful in wide range of skills like social skills, communication skills, reading skills, academics, and fine motor dexterity, hygiene, grooming, domestic capabilities, and also in job competence. Ideally, it is given for more than 20 hours per week, and it's recommended to be started below 4 years of age. It also helps in minimizing negative behaviors. Another very popular technique is asserts. The abbreviation stands for social communication, emotional regulation, and transactional support. This is an educational model. It is based on other approaches like ABA, Teach, and RDI. Social communication, we focus on development of spontaneous and functional communication, emotional expression, and social and secure, trusting relationship with children and adults. Emotional regulation, ability to maintain a well-regulated emotional state, cope with everyday stress, and learning and interacting. Transactional support is based on development and implementation of support to help partner respond to child needs and interests, modify and adapt the environment, and provide tools to enhance the learning. Another developmental interventions include focus on building emotional relationships and fostering social communication and developing social skill. Most commonly used practices are floor time, developmental individual difference and relationship based model, and RDI, relationship development intervention. These will be discussed in detail in other sessions. So intervention for communication, we all have heard of PEX, picture exchange communication system. It consists of a few picture cards or some such type of things which can be used by the children to communicate. So the child is taught to use this picture exchange communication system to approach another person and give them a picture of desired item in exchange for that item. So the child starts learning the reciprocal communication using the picture system. Another technique is that of social story. It consists of describing the context, the skill, the achievement, and these concepts are according to defining criteria. Criteria include overall patient and supportive quality, format is there, voice content is there, and learning experience that is meaningful, descriptive, and socially and emotionally safe for the child. Social skill training is also very important, very useful, which consists of providing graded and stepwise approach to train the child in starting from simple social skills to complex social skills. It's very helpful in developing social reciprocity, social building, social relationship, peer relationship, and it helps in facilitating building of friendship in the real world also. Educational assistant, a very popular technique, consists of teach it consists of treatment and education of autistic and related communication handicapped children. It is not a curriculum in itself, but rather a framework which consists of physical organization, individualized schedule, work or activity systems, and visual structure of materials in tasks and activities. Sensory integration include occupational therapists which use sensory integration therapy to help child develop like play with other children. So it's based on assumption that a child with autism is either understimulated or overstimulated. So it helps placing the child in room specifically designed to stimulate and challenge all of the senses. The aim is to improve the coordination of the brain, to improve the processing of sensory information by the brain, so the child will be more functional in his day-to-day activities. Now coming to pharmacological treatment, as I previously told also, there is no drug of choice for autism. So pharmacological treatments and options are very limited. Medication is only used if the child is unresponsive to non-pharmacological treatment. If the child is not responding to psychosocial treatment, then only medicines are used as a last resort. And when the behavior is so disturbing that the intervention cannot be done, as we frequently find that children come to us, we start doing therapy or applied behavioral analysis or some other psychological intervention, and child is not able to sit at one place. Child becomes very aggressive and throws tantrums and starts crying and showing aggression and all this. So in such conditions, the medicines are very helpful and very useful to calm down the child, decrease the hyperactivity, decrease the aggression, increasing the focus of the child on the intervention. So the role of medications is supportive to the psychosocial interventions. So in cases where the problem behavior is responsive to medicines, it should be understood that it's only a symptomatic treatment, it's not a cure. So it needs to be taken into account that the medicines, what medicines are doing is doing the supportive role. It's controlling a specific target behavior, but not a cure for autism itself. So commonly used medicines most commonly prescribed are antipsychotics. Specifically, two antipsychotics has been approved by FDA. So these are most frequently used. If the child is having comorbid ADHD or having hyperactivity as a comorbid condition, so stimulants are very useful. Some children do respond to some SSRI or antidepressant for restricted repetitive behavior, or some comorbid depressive conditions are there. Alpha 2 agonists are also very useful in decreasing the hyperactivity. Anticonvulsants are used if there's comorbid seizure disorders are there, so we need to use anticonvulsants. Anti-anxiety medicines are used in very anxious child. Sleep problem is very frequent in case of autism spectrum disorder, so many child do require sleep medicine sometimes. It should not be used on routinely, but in cases where it's very much needed, it can be used. So as I discussed previously also, atypical antipsychotics are frequently used, the most commonly being the risperidone and aripiprazole. They are very effective in reducing the irritability and hyperactivity and aggressive behavior. ADHD medicines are used in comorbid ADHD conditions like methylphenidate. In older children, atomoxetine is also very helpful. SSRI are not found to be that much effective in treating the repetitive behavior, and psychological intervention, behavioral interventions have very good efficacy in that. Antiepileptic drugs, if they are used in comorbid seizure disorder, then it's okay, but in improving the behavior or controlling the aggressive behavior, evidence is not that much. There is research on some new agents like glutaminergic agents or oxytocin, but these are although promising but at very early stage and very difficult to comment whether these medicines will come into mainstream. So for management of irritability, a multimodal approach is required. So just giving medicines is not that much helpful, and alpha 2 adrenergic agonist may be given initially for a few days to improve the irritability. Most evidence and most effective are the atypical antipsychotics when given in very low dose and giving judiciously. These are very much helpful in calming down the child. Apart from giving medicine is very very important to psychoeducate the parents. So for we need to because there's lot of misinformation going around regarding autism in internet and everywhere. So it's very important to give right information to the family, right information to the parent, and psychoeducate them that what they are going to face and what their child is going to face. So we need to tell them that autism is a neurodevelopmental problem. It's a lifelong problem. It starts from before even the birth of the child. It is not produced by vaccine as it has been popularized in internet by many people, but it is not at all. The evidence is does not at all support that vaccine does cause any neurodevelopmental problem. It is not definitely caused by bad parenting. Previously there was some concept that mothers were blamed that because of poor parenting by mothers the child develops autism, but that theory has been refuted time and again by evidence. So also that we frequently tell our clients that all children are not same, so that needs to be emphasized. Every child is unique in his strengths and weaknesses, and that needs to be dealt like that only. So early intervention is very helpful. It has been persistently found that if you start early, so the prognosis will be good. So education is not the only aim. Developing the functional skill of the child is very important apart from academic education. So we need to do not stigmatize the child. We need to talk openly and in a positive manner. We should arrange for meetings with parents of other children with a autism spectrum disorder. So these kind of interventions and psychoeducational interventions is very helpful for the parents. uh, Along with these, there are many non-evidence based treatments going around, because as we frequently find, if there is no cure for some disease, all these kind of non-evidence based treatment starts coming in. So as has been stated by FDA itself, that there is no cure for autism, and any treatment that claims that it can cure autism spectrum disorder is a lie. So it's a lifelong disorder, and intervention needs to be done for very long time, maybe even lifelong. So we need to tell or educate our parents that we should be suspicious of any claims which claim that 100% guarantee or something like that to treat. So we should always be suspicious of such claims. We should not accept personal testimonial as a scientific evidence, because what may work in one child, it's not necessary that it will work in another 100 child. So sometimes some fluke may happen, but it does not mean that it will work in each and every child. So there is no quick fix. Frequently parents come to us कि ये कुछ दवा दे दो, कुछ सिरप दे दो, टॉनिक दे दो, मेरा बच्चा ठीक हो जाए. We need to educate them there is no quick fix. It's not like paracetamol खा लिया बुखार ठीक हो गया. So autism spectrum disorders are a complex group of disorders. They are neurodevelopmental disorders, and intervention needs to be done by multidisciplinary team. Multimodal approach need to be taken, and it takes a long time to get positive and good results. So miracle cures does not exist. We need to educate that parents regarding it. This is a list of some claims that are not substantiated scientifically and should be avoided. So sometimes in absence of facilities, parents fall prey to these kind of claims, and we should always educate them that if they are not doing any recommended intervention, like we call them for therapy, we call them for occupational therapy or speech therapy or psychological intervention, they always try to avoid that, but they fall very easily fall prey to such claims of कि ये दवाई खा लो, ये खा लो तो ठीक हो जाएगा. So we need to have empathy and educate them that there are no miracle cures, there is no quick fix. The interventions for autism spectrum disorder take a long time, and if we persist on doing intervention, so definitely there's improvement in child. As we all have seen, there's those parents and children who are very adherent to the treatment, very punctual in the follow up. The positive impact definitely happens in those children. So these are my references. Thank you.